This is Dr. Pinky Agarwal, and I'm a movement disorders neurologist working at the Booth Gardner Parkinson Center at Evergreen Health in Kirkland, Washington. And this presentation is being done for the Northwest Parkinson's Foundation for the HOPE Conference. Next. So, for Parkinson's, the best care that a person can get is when you have a team taking care of the Parkinson's, and that team can consist of your neurologist, your primary care doctor, your nurse practitioner, or your physician's assistant. And other typical parts of the team can be a speech therapist, occupational therapist, physical therapist, a psychologist, sometimes even a neuropsychologist for memory testing. Being part of a community is very helpful because we can all learn from solutions we've created for ourselves so that each one of us doesn't need to reinvent the wheel. So attending community groups, and it's obviously hard during this pandemic, but we do have some virtual groups. And in fact, that's given us a wider audience and more options because we can really log on to a support group anywhere and become part of it and learn from it. It's also very important to stay in touch with your family and your caregivers because we all, as human beings, we draw strength from each other. And the more we share, the more we learn from each other. But there is one other addition that can be very useful as part of this care team, and that can be someone from the research division. So involving research in your care team can be very productive. And the focus on my presentation today is mainly how research fits into this Parkinson's care paradigm. Next slide, please. So first of all, find a team you can trust. And, when you go there, you'll feel that right fit. And then do try to involve all of the members of the team that you have available there. At some centers, you'll find them physically very close, located maybe on site. At other centers, they may not exactly be on site, but you may be able to get referrals to see these other people of the care team. Again, education, attending seminars like this one, or reading books, or going to several of the active websites, including the NWPF website, which I often refer patients to. It's certainly very up to date, and you can find local Northwest options, both for education as well as for research on that website. Exercise, you know, it's all the studies that are being done in Parkinson's show that exercise is equally, if not more important than medications. And then gratitude, it's important, it's very easy to slip into negativity. But at the same time, if we find things to be positive and grateful for, such as the fact that there are medication options out there, and in fact, there are several medication options out there that we can avail of for symptoms that can make us feel better. And then again, participating in research, it gives you interaction, it feels you're giving back to the Parkinson's community, and it feels that you're in control because you're actually helping in the development of new medications for Parkinson's disease. Next slide, please. So one of the questions is, some of the frequently asked questions that we see is, why should we participate in research? Who will be my doctor when I'm in research? Will I lose my, the doctor I'm seeing currently? Will it be safe? Why are there so many visits? Typically, I come to, the clinic only about every 4 months or 6 months. Why am I having to come so often now? And why are these visits so long? Why can't we just do it all remotely? What about side effects? What will happen if I get side effects? Who will pay for the trial, the costs of the trial? And, if I participate in research today, the drug may not come in market for years and years. I may not be able to benefit from it. So what's the point of participating? So these are some of the common questions we hear. And in the rest of my presentation, I'll try to address some of these questions. Next slide. So it is normal and it is typical to have these questions that I outlined. And so the first thing in clinical research is, and the most important part is the informed consent process. And this is something that the study site, the doctor or the research coordinator will hand to you at some point, and it is very detailed. And it's supposed to be written at a level that most people can understand. So you should not need a medical background in order to understand an informed consent. It should also, most of the times, it will be in a language you can understand. So, sometimes the research informed consent forms are available in different languages, such as Spanish. So make sure you check into that option. And remember always, research is encouraged, but it is entirely voluntary. So it is up to you to decide whether this is a good option for you. And for whatever reason, if you do not participate, it does not negatively impact your clinical care. So your care continues the same whether or not you participate in research. And consent is an ongoing process, meaning it's not that you consent just in the beginning of the trial and then you're stuck with the trial. Anytime during the trial, if you decide, due to change in circumstances, due to change in your travel plans, or any other life circumstances, if you decide that the research trial is no longer a good option for you, then you can withdraw from the trial at any point. Next slide. So why participate in research? One of the major advantages is that you have access to healthcare professionals who spend a lot of time with you, a lot of time, and sometimes you get to know the study team very well, and you become part of that research family. And, typically research is subject to very high standards of care, sometimes even higher than what regular care is, regulated by. Also, as you participate in the trial, you'll find yourself getting increased, you'll become more aware of your symptoms, you'll become more familiar with some of the terminology that's used. And during these long research visits, you'll come to understand the disease in a way that you can't by yourself at home. Also, you have the benefit of being on cutting edge research that may not otherwise have been available. You may have access to meds that you may not have until 4 or 5 years later. Also, several of the clinical trials nowadays in Parkinson's involve scans such as DAT scans, DNA analysis, sometimes skin biopsies, sometimes biomarker analysis, either from blood or from spinal fluid, that are typically not available as part of regular clinical care. And also, one of the major advantages is that these services are typically at no cost to you. Next slide. So then the question is, why me? There's so many other people who can participate. Why me? Well, if all of us thought, why me, then no one who can participate in who would participate in research. Also, one of the advantages is that every person is different, and we need representation from people, from men, from women, from people of different races. We need people who are living in different parts of the world, because geography can affect, or ethnicity or race can affect the way in which we metabolize medications. So if we have wide representation of the population in these trials, then we have results from these research trials that can be generalized to the entire population, versus if we had a small subset of similar people who were enrolling in a trial, then when we do get positive results, we are not sure, or negative results, we are not sure if it's applicable just to that small population or to the wide representation of population who've enrolled in trials. Also, early on, when people are newly diagnosed, they have the option of participating in disease modifying treatments, and they get to understand the disease better, which in turn lets them take better care of their condition. Next slide, please. So, how safe it is and what are the phases? But there's a lot of research that goes before you even participate in the first trial. So there's preclinical research in which it's tested, the drug is tested, in the lab. Then the first time it's tested in humans is a phase one, in which they're often looking at it in normal people who don't have the condition, and then you just look at the safety, whether the drug is safe in humans and whether it's metabolized okay. It's pretty much only till phase one that normal healthy volunteers can help with the disease. Pretty much everything phase two onwards, it has to be people with the condition that can help in participating in research. So phase two is often a combination of, how safe is it? Also, some preliminary data on benefit of the drug. Phase three is larger number of participants, and the main focus is to see whether the drug is beneficial in the population. And obviously, we always keep monitoring safety. After phase three, a drug, if the results can be submitted to the FDA for approval, and even after the drug is approved, even then there is more safety monitoring, often in the form of a phase four trial. These are typically, open label trials in which the medication is already on market, and then patients who are getting the medication are monitored for safety as well as side effects. And so, you'll come across these various terms like ICH guidelines, FDA regulations, Belmont report. Basically, these are an international set of guidelines that have to be followed during research in order to keep participants safe during a trial. Because all across the clinical trial, the prime thing that's being monitored is not efficacy, it's actually safety. First of all, is the drug safe? And secondary, what comes is the drug beneficial? So there's a lot of safety inbuilt into research. Next slide, please. So, typically before researchers started, there's an institutional review board, and it's actually consists of a diverse number of people. It has a few medical, but it has a lot of non-medical people. Sometimes it even has people from different religious communities as part of the IRB. You have just people with no medical background. So a diverse group of people who make sure that the trial is okay and it protects the rights and welfare of patients. Oftentimes, institutes will also have a research steering committee that will also, again, see that the trial is something that's safe for patients, and that the institution has all of the resources to conduct the trial. And all of the research staff have to subject themselves to ongoing education and training in order to conduct clinical research. Also, all of the lab equipment, etc., is monitored ongoing to make sure it is safe. And then all patient related events, any side effects that happen, are reported in real time to several reporting bodies, including the IRB and the sponsor. And so if at any time a trial is deemed that it's not safe, then a trial can be put on hold or stopped at any time. Next slide, please. So another question, why are so many visits needed? Why not few visits? Why not all virtual? So as far as the virtual question, everyone is modifying themselves to the pandemic. And yes, people are trying to shift several of these visits virtually. However, some trials that were designed and some of them do need procedures like IV infusions or maybe a spinal tap or a scan. So those and all of these are not available in portable, like these scans are not available in portable forms. So though there is a trend to try to do some of these visits virtually, several visits still need in-person visit for blood draws, for EKGs, vital signs like taking your blood pressure, pulse, physical exam. During the visits, there'll often be patient questionnaires. There'll be questions that you fill yourself, and then the doctor will ask you questions, and they'll fill that. You may be asked to walk. You may be asked to, tap your toes, tap your fingers, walk up and down. And all of this gives very important information of the safety and the benefit of a drug. And so these visits are long and frequent so that there's extra precaution and that we keep a close eye on study participants. Next slide. Why are the visits long? Oftentimes the first two visits will be long because we're trying to get a lot of baseline data on you. And then there's often, typically when you go to your regular clinic visit, you don't always have a blood draw, you don't always have an EKG, but oftentimes you will find that in research visits, you need a blood draw or an EKG or other procedures. And a lot of these are being done to monitor the safety, to keep you safe. And that is why these study visits are longer, because there are a lot of inbuilt safety mechanisms built in. Next slide. What if I get side effects? So if during a trial you get a side effect, you're encouraged to report it immediately, to the site at which you're participating. And most of the times you'll be made aware of possible side effects ahead of time. And if you do have these side effects, make sure you let your study doctor know. And what happens is all of the research participating sites in real time keep reporting these side effects. So if some kind of a pattern emerges, uh, the protocol can be modified. Also, there is something called a DATI Safety Monitoring Board. And this monitoring board periodically keeps assessing the safety of the trial. And if there are concerning side effects, then the Data Safety Monitoring Board will either alter the protocol or even in extreme cases stop the trial. Next slide. Who will pay? Typically, for the research trial itself, there are no costs. It's typically free of charge. If there are any side effects, then typically if it's anything related to the study drug itself, the sponsor will pay. And if it's just unrelated side effects, then typically people will go through the insurance. This question will be spelled out very clearly in the informed consent. Next slide. So one of the questions we hear is, am I a guinea pig? Like I mentioned, a lot of the research has been done outside the lab in non-human primates before it comes to you. So it's really very much past the guinea pig stage by the time you are able to participate in a trial. And so in a trial, rather than looking at it as, am I a guinea pig, it's actually providing you access to a medication or to some testing, maybe far ahead of people who are not participating in a trial, for who may have access to a drug or a new therapy several years down the line after it's approved. And one important thing to remember is health information confidentiality is always maintained throughout the trial. So though your information about side effects may be sent to a sponsor somewhere, you are only a number. Your name does not go along with it. So your confidentiality is always maintained. Next slide. Now, one of the questions that comes up is why placebo? Why can't everyone get active drug? Well, for anyone, if we believe that a med and we hope a med works, we feel better on it. And so at that point, the conducting a trial, if everyone gets active drug too early on, may not really have much scientific use because everyone could take the drug and feel better on it. When we compare it to a placebo, which is a look-alike pill, which is more like a sugar pill, then we know we can, in an unbiased manner, because generally the investigator or your treating doctor doesn't know, you don't know, so whether you're getting the active pill or the placebo. So it's a non-biased way to just clinically assess whether a medication is actually helpful or no, because there have been several meds in the past that we've heard reports of that are helpful in Parkinson's. But when the actual trial was done in an unbiased fashion, we felt it was actually not helpful. So even to prove that some drugs that we might be spending time and effort and money on, to just know whether they're helpful or no, it's helpful to have an unbiased clinical trial. Next slide, please. So just to kind of simplify, because you'll hear about a lot of Parkinson's trials, oftentimes you can categorize into like 3 buckets: patients who've just been recently diagnosed, patients who have motor symptoms and non-motor symptoms. And there may be some trials that may, that may cross the spectrum, and patients could participate from all 3 buckets, could participate in those trials. So some of my future slides will be going a little bit more specifically into some Parkinson's trials, especially showcasing the ones at our center. Next slide. Now, if you look at it, these are most of your currently approved Parkinson's meds. So we see there are several formulations of carbidopa, levodopa. There's immediate release, slow release, and there's Rytary, which is a combination of immediate and slow release. Now, the ones that you see highlighted, these are studies, research trials that have been conducted at our site over the last few years, last 5-6 years, and you'll see several of these are already approved. So when we conducted the trials, these were not FDA approved, and these are now FDA approved. So really, there's not so much of a lag anymore. By the time you participate in trials, it's quite possible that in a few years from you participating in the drug, it might actually be approved and on market for usage. So then there's also inhaled levodopa or Imbricia. There's Duopa, which is an intestinal gel for Duopa. So those, the highlighted ones, we conducted at our site, and these are now approved. Then there are dopamine agonists. There's pramipexole, ropinirole, rotigotine. There's also apomorphine injections, Apokin, and we also did the trials for the sublingual apomorphine. We just recently got approved this year. Then we have MAOB inhibitors, selegiline, rasagiline, safenamide, COMT inhibitors, Comtan. These basically make the carbidopa, levodopa stay around longer. Then there's Stalevo, which is a combination of entacapone, carbidopa, levodopa. There's tolcapone or Tasmar, and very recently opicapone or Ongentys. That is a new FDA approved medication that, and actually this is incorrect. Our site did not participate. We will be participating in an open label trial perhaps. But opicapone recently got approved. It's similar somewhat to entacapone, except that you dose opicapone only once a day. There's also amantadine, and amantadine ER. So we were part of the Gocovri trials, and that med is on market now for treatment of dyskinesias. Also, you'll see adenosine A2 antagonist Norians or estradiol, and we were part of those clinical trials several years ago, and that med is now on market for treatment of wearing off symptoms. Next slide. So treatment of early Parkinson's, some of the options is you can use, we can use symptomatic treatment, we can try to use protective treatment in the form of trials. Early PD, sometimes people have no symptoms, they can afford a wait and watch approach. But instead of just waiting and watching and not taking any medication, this is an ideal time to participate in clinical trials. Because if you don't need symptomatic medication, if you do end up on the placebo arm of a drug, you're no worse off. But if you do get the active drug, oftentimes there are several trials out there that are looking to see if they could slow progression in Parkinson's. One of the other options for treatment of early Parkinson's can be using a mild medication like an MAO-B inhibitor like selegiline or rasagiline. But again, this is a window when someone is newly diagnosed with Parkinson's, and if they don't really need symptomatic or they need very mild symptomatic treatment, then they can participate in a clinical trial, because oftentimes these trials do not allow someone to be on symptomatic treatment. And typically, if you can be off med for about 6 months or 9 months, you can participate in a trial. Next slide. So some of the trials that are going on at our site for the patients who are recently diagnosed are ProSeq, PB2, and Neurally. Next few slides, I'll give some more details on these trials. Next slide, please. And then we have other trials, not for newly diagnosed, but for patients who have non-motor symptoms, such as Parkinson's disease with constipation. We have a trial. If patients have been constipated for more than 6 months, they can enroll in this trial, and it's an oral medication. Patients who are having trouble sleeping, trouble with sleep maintenance or initiation, there's a medication, suvorexant, which is currently FDA approved. But here, we are looking specifically for its role in Parkinson's sleep problems. There are also trials for Parkinson's with motor fluctuations. And one of the meds being looked at is even a longer duration of carbidopa-levodopa. So right now we have Rytary, which is extended release. This is looking at a med that's even longer duration of carbidopa-levodopa. We have trials for Parkinson's disease with orthostatic hypotension, which basically means lightheadedness on standing up. And then all patients who have Parkinson's disease, or even patients who have a high family risk, who have several other members in the family with Parkinson's, they can participate in the ROPAD clinical trial, which is for genetic testing for people with Parkinson's disease. And then again, the newly diagnosed ones were Neurally, ProSeq, PB2. Next slide, please. So Neurally is for patients who are newly diagnosed, and it's looking at exenatide in patients with early Parkinson's disease. And it is compared to a placebo, but it'll look at how well tolerated and if it is beneficial in patients with early stage Parkinson's. Now this, next slide. This medication tries to alter the Parkinson's pathology. Now, typically we know in Parkinson's pathology, there's alpha-synuclein, which is present in Lewy bodies in the brain. Now, next slide. So the right side, you'll see what a normal dopamine neuron looks like. And then on the other side, uh, you'll see these, round blob of a protein, which is alpha-synuclein. And that is the abnormal protein that we consistently find in Parkinson's disease. Next slide. So coming back to that trial that I was talking about neurally, so exenatide is currently approved and it's widely used to treat diabetes. And it's a subcutaneous medication. So what the aim of the trial to see if it limits nerve cell loss and if it could delay disease progression. And does not, in diabetes, it's obviously used to reduce the blood glucose level. But when they've used it in healthy animals, even at higher doses, it does not seem to cause low blood glucose, which is why it can be used, but obviously with safety monitoring in Parkinson's disease. Next slide. Now, Proseq, the medication being used is a tyrosine kinase inhibitor, and it's being done at our site right now. It's a phase 2 randomized double blinds. That means some people will get active, some will get placebo. But it is an oral medication, and there are a total of about 12 visits, and patients will be in the trial for about 40 weeks, and is looking to see if it could alter the progression in Parkinson's. Next slide. Another medication for newly diagnosed is the P2B trial, in which patients who are early, but they feel that they could benefit from symptomatic treatment, could enroll in this trial. And the study medication is a combination of low-dose pramipexole and rasagiline. There's also a placebo arm. The the trial is short in duration, only 3 months. Next slide. In the ROPAD trial, which we talked about genetic testing, it's a very exciting trial in which really anyone with Parkinson's disease can participate, or anyone who has a strong family history of Parkinson's so that they're at high risk. And in this, patients come to us. It takes about 45 minutes. It's just a one-time visit, approximately 45 minutes. And then patients give there's one blood draw. And then on the basis of that blood draw, we can identify if they have any of the genes, currently known genes, that make them more prone to Parkinson's. It also aims to identify patients who have either the LRRK2 mutation or the GBA mutation. And there are specific trials being done currently to try to develop meds that are for these specific genetic subtypes of Parkinson's. However, those are optional. For patients who have PD, they can contact our center. It's a one-time blood draw. And in about 4 months, people get the report of their genetic, if they have any of the gene mutations causing Parkinson's. Next slide. For Parkinson's with constipation, it's a randomized double-blind study, a total of about six visits in 6 months. And it's an oral medication, and there are no colonoscopies, etc. needed. Next slide. This trial is for patients with trouble falling asleep or staying asleep. And as long as they don't have significant sleep apnea, they can participate, and they get the benefit of 3 sleep studies. And there's a medication called, it's FDA approved for sleep problems, Suvorexant, or it's marketed as Belsomra. It's looking at whether Belsomra, which actually suppresses wakefulness, whether it's helpful in sleep initiation and maintenance in Parkinson's. Next slide. There's, with Parkinson's, we know as one continues using carbidopa, levodopa, sometimes the medication does not last long enough. So the med starts wearing off. It's called off time. So the trial for off time that we have is looking at this medication called IPX203 and is compared to carbidopa levodopa immediate release in patients with who are having off time. And it's a relatively short trial, only about 20 weeks. And after the trial is over, there might be an open label extension to follow. Next slide. So sometimes patients with Parkinson's will notice lightheadedness or dizziness on standing up. So that can happen due to a drop in blood pressure on standing. And one of the trials is looking at an oral medication, droxidopa, in patients not just with Parkinson's, but with also MSA, which is Parkinson's plus, to see if it decreases the chances of orthostatic hypotension. Again, oral droxidopa is already FDA approved for treatment of PD and drop in blood pressure. But like we discussed, this is a post-marketing safety trial. So it's a phase 4 trial to see that even after the med is launched, how safe and effective it is. Next slide. So thanks to research studies, thanks to the numerous research participants who've and to the research personnel conducting these trials, several new meds have come to market recently this year. And several patients at our site and in this area have received access to drugs in the trials long before it received FDA approval. Next slide. One of the examples of this is the recently approved sublingual apomorphine. So, there used to be an injectable form of apomorphine, but it's now FDA approved as a sublingual apomorphine. It sort of looks like a Listerine breath strip. It's very fast acting. And if one has an off episode, one just puts it under the tongue and then it gets absorbed very quickly through the blood. And you can have side effects of sleepiness, nausea, your typical dopamine kind of side effects. But the drug can be very effective in quickly turning someone from off to on. Next slide. Another example of a recently approved drug is opicapone, and it's used to treat off episodes. It has a half-life of about 3 hours, and it's just once a day capsule. And what it can do is it can extend the duration of action of the carbidopa levodopa. Next slide. There's also inhaled levodopa. And again, these trials were done just within the last few years. This is also for patients who have off time. This is more for acute treatment. So if someone's having off time and they quickly need to turn themselves off, then they inhale the levodopa and it gets absorbed through the lungs. So it shaves off the time for the med for someone to swallow the med, for it to get absorbed in the blood. It's rapidly absorbed through the lungs and patients can turn on. And the full dose is 2 capsules and it can be used up to 5 times a day. One of the possible side effects can be cough. Next slide. Duopa has been approved for the last several years, and it's of levodopa that's delivered to the upper intestine through a PEG-J tube. So there is a stomach tube through which another tube goes to the upper intestine. But outside it looks pretty discreet, just like a wearable pump. And the levodopa gets continuously pumped into the upper intestine, which is where it's absorbed. So patients can have a significant improvement in motor fluctuations. Next slide. So the clinical trials at the Booth Gardner Center, if you're interested in any of the trials that we mentioned, this is the number to contact us at, and that's the email. Not only are we conducting trials, but several of the hospitals in our area are doing it. So if you go to clinicaltrials.gov, that's another way of finding trials that are close to your center. And so with that, I'll conclude my presentation. And I thank you so much for your attention today.